4 now.
Part of this course, and it's a pleasure always to speak at this IC. So I'll be talking about management of stage 5 ROP. So first question which comes to your mind is which cases should I operate? So the ICROP 3 gave a very good classification of stage 5 A, B, C and divided stage 5 into 3 parts. So stage 5A, when you get, basically optic disc is visible on ophthalmoscopy and says an open field kind of attachment. So the question which comes to my mind when I see a case like this, can we make this outcome better than what it is now? So many times you might not be able to make it better than what it is now. The lens is a very important component of the refractive status. And if you have to go in, you have to eat away the lens, and then the patient will become aphakic and mostly will become amblyopic. So if you cannot make it better than this, the macula might be attached, might not be attached, there might be shallow RD there, the disc is visible, then it might be better to leave it sometimes. Again, stage 5B, optic disc is not visible, little 5 places is there, and this huge closed funnel situation is there are no anterior segment changes. So again, you have to think the same thing, can I make this outcome better? So mostly, these are the cases which are operated, where just like people like you who are operating PVR D3, you know that if you open the central membrane, the things might start to open up as you progress into the funnel. So sometimes these cases might open up. So these are a good situation where you want to go in and try to open up these funnels. Stage 5C is a different game because mostly the anterior segment gets involved in these cases. And so if you see on the left side, the top left photo, again, the corneal opacity is there. So many people like to operate in 2 sittings. In the first sitting, they want to, remove the anterior posterior synechiae, clear up the cornea, then wait for 5-6 weeks, and then go in for a second stage surgery. But many people like to go in for the photos which you see on the bottom left, where it's mostly like a 5B only. The moment you open up the synechiae, it behaves mostly like a 5B. So it depends on how you want to go in. So again, the question you should ask is, can I make this better? If you can make it better, then you should give it a try and go inside. So basically 5ABC is a continuum of disease which basically is progressing from different stages, and as it gets worse, the complexity of the surgery becomes difficult and the funnel continues to close and anterior segment changes come into the picture. A word here about cases which come in stage 5 at an early stage. So here, they have not really stuck behind the lens, but they are coming at low PMA, let's say around 45 weeks, 42 weeks. When it's gone into stage 5 ROP, these are vascularly active and they're progressively closing up. So these cases are even more difficult to operate because there's a high chance of intraoperative bleed, post-operative bleed, and the disease might continue to progress despite your surgery very actively. So these are much more tougher cases to operate than burnt out cases coming to you at 60 weeks or 70 weeks PMA. So I'll talk about the surgical technique. So the SN group has given a very nice idea about the different tractional forces which are there. And if you see here, this is how the traction tends to proceed and progress into stage 5 ROP. So people who want to start stage 5 ROP surgery should understand the pathoanatomy of how the stage 5 ROP is happening, and then you can progress further with it. A lot of this will depend on how much anterior peripheral access do you have. Is the posterior peripheral access available or not available? Which will decide your approach. You want to go clear corneal or you want to go through a scleral approach. So many people like to do a UBM here in this situation to find out which area, is particularly the thing is not stuck. In those areas, you can try a scleral approach if you want to go in. Or maybe that lens is not involved, it's pretty low TRD. Again, you want to find out where you want to go in through a posterior approach. So if you just want to go through a posterior approach, then you you do not want to insert the trocar completely, as has been shown by Madam earlier as well. So you do not want to go in fully. So I just put in half the trocar and then I slide the rest of the canal in so the trocar does not go in. Hit the retina in these situations. However, in most of the cases, it's all stuck behind the lens. So this is how I go in through this approach. So this is a 23G MVR which is going in, through which 25G instruments go in. So this allows for a snug fit as well as mobility of the instruments. So 3 ports clear corneal incision is made, and then you can go inside. So now you're going to do a lensectomy there and remove the posterior synechiae. So now you have this dense retrolental membrane which is sitting there. So in an area where the retina is not stuck, you look for a clear area with the endolight, and there you can create an opening in the retrolental membrane. So you see there's so much opacity is there between the fovea and the light source. So all these opacities have to be removed in between. You see we have not cut the iris. The iris is a very important component. We should not spoil the cosmesis of the eye. And you can then continue to eat away all this tissue in the periphery and cut with scissors, etc. and continue to dissect into the periphery and open. So here you see the central open approach. We haven't gone into the periphery much. But you see as you continue to eat into the central part, this I'm just trying to show you here, there is a last bit of tissue which goes out, and there if you see, there you can see that the disc will be there. So there you can see the disc is there and the posterior pole is there, which is almost very shallowly detached in that area. And then, after doing all that, I like to hydrate it and then we'll just inject it. So it comes a sutureless closure, and air is injected in the end, and because it's an MIVS system, it does not leak and holds on. Obviously, there's no ego about this. If you have done a lot of manipulation and the wound leaks, then you should go ahead and suture it. So a lot of the funnel access, the posterior funnel access, a lot of it depends upon that. And as Dr. Gopal has also very nicely described in his article, if you've got a very narrow funnel configuration, it's a risk factor for a poor outcome in these cases. So if the funnel opens up very nicely, then you can have a better outcome than a funnel which, does not open. And obviously there's a learning curve about this, and people who get started into this need to learn about this. So is the USG actually useful? So I'd asked Dr. Tracy this. He said, it's of not much use, and I just go in every case and I try to do it. So you can try ultrasound in initial cases, and these are open configurations you might find easier to operate initially once you get started, rather than getting stuck funnel which is totally closed and it might demotivate you. So it's better to start with an open funnel. So this is another case to show you that it opened up like this. As I showed in the earlier case as well, the posterior funnel opened up very well. So this is not a common outcome. This is a rare outcome. I'm just trying to show you that these babies are left for blind, and as Dr. Jalali also highlighted earlier, Dr. Gopal also highlighted, we should go in for this surgery for these cases. You don't know how much the funnel opens. Once you go inside and continue to open, it might continue to open. And of course, a lot of these will be like this also. So what I want to show you here is that a lot of these cases have been operated stage 5. You see they are in different levels of opening. They are in different levels of contracture. They might or might not look good to you. But the important thing is here, all these children have mobility. They can walk from here to that door without crashing. A child who has so much opacity in between will just have a PL plus minus. These children have some kind of high movement, some kind of thing which will allow them to go from here to there, to the toilet. They might be able to see a parent is standing there. They might not be able to see their face exactly, but might be able to see that this is my father, this is my mother. They might see there's a chair here. And this changes the life of the child, changes the life of the family, and empowers the child. So sometimes, it might not be stage 5 ROP, although it appears there's a lot of, things stuck there. And once you go inside, you might find that it's actually stage 4B sequelae, which you just opened up, and suddenly a large part of the retina appears to be attached. So here, just trying to show you, you open this up, and a large part of the peripheral retina appears to be, attached in this case, just a central TRD is there. So that kind of surprise might happen. The important thing is to expose the macula, and this can get exposed in a large number of cases, although it might be detached. So once you get it, it's better not to, ruin it, not to, do too much dissection there, so that, the macula might be thin, might be cystic, might already have a pre-existing hole. So better not to, just let it go away. The benefit which you got for opening the funnel, better to prevent the reclosure of the funnel rather than, creating a macular hole. And the standard teaching is if you get a break, you close the case. So I never close the case, even if I have 2 breaks, 3 breaks, because there's no intention. So what I'm trying to show here is, you see I'm doing the same thing, and the dialysis happened in the periphery. You can see a lot of subretinal fluid is coming out from the top right side. So I don't stop my case, I continue to do it because it's a last ditch effort for this child. You are even not going to laser, you're not going to put oil, you're not going to put gas. So you're not going to make any attempt to, settle this. So I continue doing this case, and it doesn't interfere with me if it's dialysis happens in the periphery or break happens in some particular part. So I continue with that. I don't stop the case. A lot of people use adjuvants to remove the vitreous membrane. A lot of people use viscoelastics to do it. I don't use it because sometimes it can go subretinal and it might further create problems, and I might not be able to remove it completely. But a lot of people like to use viscoelastics and staining agents, and it helps them to operate these cases. So you can also try that, and it might work for you well. A small tip before you close these cases, what I'm trying to show here is that everything looks fine. So I just pinch the cannula, and it starts to bleed. So these are bleeders which are not happening because of the VGFI. So if you pinch it, the bleeders come up, you then dithermize them, because they are not appearing to you when you are right now in the middle of surgery, but they are there. So the moment you take out this cannula, this is going to bleed, and everything is going to get spoiled. So right now we're in the middle of surgery, I'm just pinching it, and you see this is happening. And just the last 1 or 2 slides. So improving closure, if you're not going to get good gain, at least don't mess up the cosmesis of the eye. It's better not to eat away a large part of the iris, better not to mess too much with the decimates, create coronal opacities. I like to do it sutureless. Obviously you can suture it at times if you want it. So this helps in a good cosmetic outcome. Even if the child sees something or does not see something, don't mess with the cosmesis of the child, which reminds the parents every day that something happened with the child. And I think this is the most important of all these, whether you operate or you don't operate the child, and whatever little the child can get, it's best to keep that with the child. So this is very important. Visual rehabilitation, I think, is the very most important part. Even if you operate, you don't give him proper glasses, he's going to become amblyopic. So all the benefit is going to go away. And even a child who's, let's say, in stage 5A has some kind of vision, better to rehabilitate them, empower the child, and also empowers the family and the society. So thank you so much.